their sort of keenness to join us. In future, I want all of you to participate, or those of you who want to do should participate. Now, today, the session is going to be planned as follows. First of all, I'm going to do a sort of a revision. Whatever the part one was, there is a typo here. This was the part one which we did on 22nd of August. So I'm going to go through it in about 35 minutes or so in the beginning. And then we will hand over to Dr. Ram Chetal, who is going to go through two of the topics which he has selected. One is top tips on setting up a learning from errors meeting, case-based discussion on a typical learning from errors meeting. So it's a huge subject and there are too many facets. My idea is, first of all, to go through an overview to give you the overall context and the history, etc., and the benefits, and then how it is done. He will sort of take over. I want you to, we will ask you many a times if you have got a question. I want it to be an interactive session, not mine, but the second part, Ram's part, where he will ask you to any questions in the chat. Please feel free to ask him, and so that any queries, any doubts, any questions, this is the time. I've sort of planned today's session with a lot of flexibility time-wise. So there will be a lot of time. Utilize this. In the end, we will stop at 9 p.m. That is our schedule for today. But if there is time, I've got cases to show you, but I'm not worried because cases I will show you next time also. Main things are these two talks. One thing which I warn you is that there is going to be a repetition. And this is what idea is. Once you learn a new concept, there has to be repetitions. And I am a huge proponent of, we call it type 4 times 4 theory, where you revise something 4 times, then you remember it. So that is why I'm doing a bit of fast revision. And many of these things he will repeat again. So it's intentional. Please remember that. So quick revision. On 22nd of August, we presented our first part of this project is the word I'm using, because we are going to continue it off and on sessions, for next years, should I say. Now, last time the aim was to explain to you the concept of RCR's realm, radiology events and learning meeting concept, and to describe how learning from our mistakes makes us safer radiologists. This is very important. You have to be convinced about the idea, and only then you will sort of embrace it. So this is very, very important. And of course, our main aim as we proceed is to give access to all of you. Anybody who wants to use our platform, we will plan in future sessions where you people will be sort of presenting. So I want it to be part of it. It will be a sort of a collective learning type of a project. And in future, I'm sure many of you will participate in that. Now, the sequence of presentation last time was, are there any mistakes in healthcare system? What is no blame culture? Do radiologists make mistakes? The history of RCR's realm, how we conduct realm at Basildon, my own mistakes, and what did I learn from them? You remember I showed you my own mistakes. And please remember, everybody makes mistakes. So one has to learn from them. So mistakes in healthcare, the data is unbelievable. You don't realize it, but approximately 1 in 10 patients suffer from harm in healthcare environments. 3 million deaths each year. And in UK, it is calculated that 1 in 20 are in that category, and 12% of these groups suffer from permanent disability or they die. And in NHS, England and Wales, up to 10% of inpatients, they experience adverse events. So huge, a number of events happen. Another thing which I want to highlight it, and this is from the GMC, as in General Medical Council, and you remember that those of you who are from overseas, that this is the governing body, the licensing, etc., of doctors are under GMC, and they always tell us that why should we be on top of our profession, because of patients' trust. 85% of patients, or not patients, I should not use the word patients, the population, they trust doctors. And look at other categories, 12% and 16% and whatever. So this trust we have to maintain. This is the main thing, that people, this trust, we cannot breach this trust. So doctors have got a duty to their patients. And it is our continuous endeavor to maintain that trust. And learning from mistakes is part of the same exercise. So remember that. Now, no blame culture is an extremely important concept to remember. And this is what we have learned from aviation medicine. In the aviation industry. I told you today I'm skipping all the details, but I told you narrations that how aviation industry learn that if you have to learn from an event or from a mistake, then there should not be a blame culture and naming and shaming and that kind of a thing. No, it has to be an exercise of learning from your mistakes. So this no blame culture, I explained to you in detail last time. I showed you many example in NHS where in the past and accidents have happened, which happened again and again. And finally, we learn that we will, if we adopt this concept of no blame culture, only then we will grow and we will become better. So there is a lot of, it goes on, and this is, so many papers, so many concepts which have been elaborated on the same lines, that in NHS, moving from a blame culture to learning culture in NHS, etc., etc. This is from a publication, but I just want to read it from here, which will give you a good summary. If we place blame on doctors making human errors, we encourage them to hide their mistakes. So this is human response. Nothing will change. We won't learn from our mistakes, and patients will continue being at risk from preventable errors. Please remember that if you learn from your mistakes does not mean that there is absence of accountability. So these processes, don't confuse them. Learning from mistakes is a sort of an educational exercise, but accountability, senior, events, legalities of things, if harm has happened, etc., is something else. But we have to learn. Whatever had happened has happened, but we have to learn. So that is the main thing, and these are two different subsets. For me, I also reflected last time on my own journey. I gave a NHS consultant interview in 2005. So I'm from Pakistan, and I had absolute no idea of this word, no blame culture, when I came here. And preparing for that interview told me that there is something, no blame culture. It was something new, a sort of a cultural shock for me. And I really embrace that. I love that idea. And the more I'll reflect on it, I'm a huge proponent of this idea, and I practice it. And, if I make a mistake, actually, I sort of, in front of everybody, I talk about it. And this is our role as seniors or whatever, because first of all, one has to realize that every human being will make mistakes. Number one, there's no shame to it. The main thing is that you have to learn from it, and you have to be a role model, and you have to show integrity and character and everything. And this is how you will grow. And one mistake you will make, then the same mistake you might not make next time in your career, and your colleagues might learn from you. So it's a beautiful concept, which I told you my journey last time in about more detail, but I was just reflecting about that. So do radiologists make mistakes? Many of you think radiologists, no way, we are the best. How can we make mistakes? So the truth is, or the fact is, to the contrary. Please remember, radiology is such an important field now that 87% of, according to RCR data, this is UK data, of course, hospital patients go through, 87% of them go through radiology. Simple as that. Correct diagnosis means correct treatment. Wrong diagnosis means wrong treatment. End of story. So we are, I use the word, we are in the solar system of hospital medicine. We are the sun. Believe me, this is how we practice radiology in UK. We are the sun. We are next to the A&E. Every patient comes through us and then goes to a ward or whatever, and then treated. So everything rotates around us. If we get it wrong, everything goes wrong. So I don't want to overload you with a lot of studies which I showed you last time, but at least 3 to 5% is the error rate, and means in about 40 million radiologist errors per annum are made in the world. Huge numbers, right? Now, types of error is very important subject, and maybe I will elaborate these things again and again, because this is how you learn. And please remember that many of these things are, the beauty is that many of these things are tested in the FRCR exam, and you don't even realize that these are tested actually. And so the there are two headings. One is perceptual errors, and then is cognitive. These are, you just fail to identify finding, and here you make misinterpretation or misdiagnosis. Now, I want you to slightly concentrate on this. And this is a key message for you. And please remember, most of these are relevant for FRCR 2B exam. Many of these things are asked in the exam. You don't even realize it. And many of these things are asked in the exam. These are the buzzwords. Now, these are the type of errors, and this is the explanation, and this is the percentage. If you see the top two, 42% and 22, these are the most common. Underreading means abnormality visible, but you did not report it. Simple as that. But look at this one. Satisfaction of search. You might have, heard me talking about satisfaction of search so many times. After having identified a first abnormality, radiologist fails to continue to look for additional abnormality. 22% of errors are this. And that is why it is asked in the exam again and again. Faulty reasoning, of course, makes sense that it was a liver abscess and you diagnose it as a liver tumor, and there was enough evidence that this is a abscess. That will be 9%. Abnormalities outside area of interest. I show you, this is my one of the favorite areas, because it as a teacher, I sort of reflect on this, that if I train you on this aspect, I make you a safer radiologist, because you have to have robust protocols. Only if you have got robust protocols, then you will not be in this 7% of cases. Abnormalities outside area of interest. So many of these are in the first or last image of CT or MR, sequences. So we also use other words like edge of the film case and things like that for this. So other bits are satisfaction of report, failure to consult prior imaging, very important, inaccurate or incomplete clinical history. And this is something which comes under communication, where the correct report was not sent to the examiner, to the clinician. Now, key point is that from next next session, I will actually show you real life cases, and you will see that how beautifully you can learn from them in this category. So, so I will give you examples after examples and after examples of these things. So please remember, many of the cases of FRCR, these things are checked. My own mistakes and what did I learn from them? I showed you. I don't have time today to go through my own mistakes once again. But please remember, I showed you this study, which many of you might have seen. This was conducted in Boston in USA, in which these were there is a term in attentional blindness. Inattentional blindness is a phenomenon where people miss unexpected objects due to focused attention. So they are focusing on something and then they miss everything else. A radiologist cannot afford it, by the way. Radiologist has to, first of all, look at lung nodule and then look at, what is happening in the bronchus and then look at effusion, everything, and bone and etc. etc. So they did this study on expert radiologists. Remember this, 83%. And what they did was in the final image, now there is a lung nodule. If you look carefully, there is a gorilla here. If you look carefully, there is a gorilla image here. And 83% of them, they did not, they did not pick this up. So the point is that if you are an expert, you can still make mistakes. This is the main point to remember. All of us can and all of us do make mistakes, and we are human. So this is the big message. Now, I showed you my own mistakes. I showed you a conventional subarachnoid hemorrhage where I was distracted, and this patient, this was the biggest mistake of my life. It was subtle, by the way, but I think the main thing was that I knew about it. I teach about it. I have taught maybe hundreds of people on imaging of stroke, and I made the mistake which I used to tell my students not to make. So humbling moment, but this is what it is. But I gave you the narration of what have happened at that time, and I was distracted, right? And it was not my duty to report this. I was in a meeting. Somebody asked my opinion casually, etc., etc. That happened to be the biggest mistake of my life. And a patient was thrombolized, should not have thrombolized, ended up having bleeding, and we lost the patient. We'll come back to this. I also told you what I have reflected in the last few years. Uh, I have reflected on this that at times, uh, for example, there was a MR of prostate in which there was a mixed duct type IPMN in the pancreas. I did not pick it up. And why I did not pick it up? Because they had done a T2 weighted sequence of the upper abdomen as well as T1 weighted sequence. And maybe I had not seen the T2 weighted sequence. This is what my reflection is. I've got liver cases, I've got MRE cases in which in the liver there was an arterially enhancing FNH, which was only visible on arterial phase and nothing else. So I did not pick it up because I did not look at the liver on arterial phase. Take home point, what did I learn from these? That on each and every sequence in MR, look at everything. This is what I learned. You cannot just see outside the area of interest on one sequence and then you think that, because it might not be visible. So on a MR of the brain, for example, there is a masticator space mass, which is only visible on a T2 weighted sequence, and you see the masticator space on a T1 weighted sequence, then you are going to miss it. So this kind of things, uh, which I have learned, and so take home point is that you have to again and again reflect on your protocols and make it more and more robust. Duty of conduct, I told you about it. The greatest mistake of my life, this thing here. And this is your duty, but when you do a mistake, you have to be open and honest with your patients. A doctor has to have be the most, integrity wise, character wise, has to be a role model.
नहीं पंजाब के स्कूल तो कर
You have to what we call you just one second, let me mute all, right. So duty of conduct is that if you've done a mistake and there is a harm or something, you have to tell the patient or the next of kin. You have to own it. End of story. And this is what we did in the case which I told you. And I told you how did it go and things. Very unpleasant, you don't sleep for days and weeks and months. But that is it. This is your duty. From here, you come to the RCR's realm concept. So this is the concept. You can see it, but of course, Ram will go in more detail on the website. And this is what it is: radiology events and learning meeting. Uh, to first of all, you have to accept that there will be discrepancies, and then you have to have systems in place so there is mitigation of them and etc. etc. I don't want to go into details of this. But if you see this project of RCR, which is a trailblazing, some of these slides, if you see, are were provided by to me by kindly by Dr. Ram Chittal. So these are the acknowledgements, and this has been a long journey. And if you go back, there were papers coming in 1990s from various parts of the world. This one is from USA, discrepancies in plain radiograph in emergency medicine, 1998. Similarly, in BMJ, reducing errors made by emergency physician in inputting radiographs. People did realize that things are happening. And this is the first sort of a meeting which was, I think, in this department, radiology department, or of Wellsgrave Hospital NHS Trust 2000, they started this trailblazing once again. And there, many studies kept coming. Look at this from evolution of real safety culture will only exist when the radiologist who made the error views such feedback positively. This is the culture what I talk about. First of all, the culture is you have to accept that you will make mistakes. Then you have to own those mistakes. I do it publicly. And you don't have to do it publicly, by the way, because I think that I'm a senior person in the department and I have got that role to influence, but you don't have to. You just keep anonymized. Uh, then positive feedback, you have to take it positively that, oh, I will learn from it. You will feel very bad. You have to feel bad. You have made a mistake. But that doesn't mean you hide, behind something and then make it once again. So this is the cultural thing which I am talking about. And so what happened was that there is a history of how it progressed, but ultimately 2010 onwards, in most of the departments in UK, we used to call them learning from discrepancy meeting. We started that. So I joined this where I am in 2006, and I think in 2008 or 9, I don't remember exactly, we had started it. So on this slide, you have got the pioneers. This was their idea. Dr. Ram, who is our guest speaker today, we are very honored. He is one of the pioneers of this idea. And he and Dr. Priya Suresh, who is right now a medical director in RCR, they conceived it, took it to the RCR, and then as an RCR project, it started officially as a READ project in 2012. So today you are going to be with the founder himself. So great time for us. These are the leaders of Realm. I think initially the name was a program director and then it changed to chairs. So Priya Suresh, Paul Spencer, Mary Rory, John Smith, he has just uh, finished his longish tenure, and then Rachel McGuinness from Manchester, she has taken over quite recently, actually. Initially, this was known as READ, which is Radiology Events and Discrepancies. You look at this word D. Then they said that if we remove this word, discrepancy, and we use the word learning, human factor is psychology-wise, more and more people submit cases. So the name was changed to REA. This is the website. You can go on this website and you can see the standards for radiology events and learning meeting. And these events, these standards, of course, will be talked about today. And RCR has got this, within that, there is a facility for all of you to participate. Basically, you fill up an online reporting form, you submit an anonymized case with learning points. Everything is anonymized, your identity, your hospital identity, everything is anonymized. This is read by the real panel, and those ones who are selected are then published in this format in a quarterly newsletter. And look at this learning points, and these are the images, and this is a small text included. They have done very well. They have published over 45 newsletters, and this is the timeline from real to real and then to real, and they are going on and on, and they are influencing the world. I was very recently in Greece about 3 weeks ago on a conference, and I talked to many people there from Germany and Switzerland, etc. There is a huge, they wanted to know more that how do we learn, they use the word errors, that how do you conduct error meetings and things like that. But to the credit of RCR, that I think as an institution, they have made it, and in all of NHS, it is practiced. So this is something great, which is not done in many countries. So many departments do their meetings in Europe, but it's not standardized like this. The real team has propagated this in internationally, many things they have done in conferences, India, Pakistan, West Indies, USA, etc. And they have worked with many departments overseas and with many radiological societies, etc. And this is a role model department. This is from India. I think Ram will talk about it. They started it, and it's beautifully written if you read this in the newsletter, that what were the challenges, and they have successfully uh, you know started this meeting in there. In this is in Vellore in India, uh, Christian Medical College, Vellore, India. So and one thing which I want to highlight is that next 13th and 14th of November, this is the fifth Realm conference. It is in Cambridge. So those of you, it's of course online. It will be online also available, I think so, if I'm not wrong. And those of you who want to attend, it will be a good idea. By the way, we DKT as a platform has been invited there, so I will be also presenting my part there. How do we conduct the real meeting at Basildon? I had told you I'll just go through in 5 minutes, but this will be repeated by Ram in more elaborate fashion. The key thing to remember is that, as I elaborated in the beginning, that do not confuse the concept of realm with any of these things. If a mistake happens, if something is in the medical legal world, harm has happened, there are many things which will, a hospital or a healthcare system, you will go through, like complaints and, even coroner's court and legal cases, etc., etc. Don't confuse this with this. Here, from the same cases, it's very simple concept. Whatever has happened in this world, just forget about it. Anonymize it totally. Nobody should know whose case it is, whose mistake it is. Number one. Number two, anonymize the patient, of course, and learn from it. This is the concept. So this is the main thing that from these cases also you can learn. This is the concept. So in our department, as in Basildon, we have got a team of two consultants who lead this, the real leads. They are the real leads. Initially, we used to call it a discrepancy meeting, as I have told you. Now, of course, we call it a realm, as in the RCR terminology. This occurs every 6 to 8 weeks. There are more than 10 cases in each time. At times, there might be 20 something cases. Attendance register is maintained. RCR guidelines are that all reporters should attend 50% of the meeting which happen in a department. So please remember this. So attendance register is maintained. Now, initially, these were all face-to-face. Of course, then came COVID, and then we at times do hybrid model, because in this model, half of us are sitting in a meeting room and half are online, and sometimes it is completely online. Lately, this is more often going on. Who attends? Anybody who reports attends. So it will be consultants, it will be registrars, as in trainees, and it will be reporting radiographers. So please remember, in UK, there is a concept of skill mix, and many of our radiographers, they report plain films, A&E films. Some of them even report chest X-rays, abdominal X-rays. So, and of course, if there is an ultrasound discrepancy, then the sonographers, they will also attend. So all of them attend. How are cases selected? So the cases are submitted to conveners. So the two consultants who are, everybody emails them the cases and the narration. So who emails them? At times, these are the clinicians who have picked up a discrepancy. At times, these are our own consultants. At times, these are juniors, juniors, and they have got this system where they just highlight it to convener, and at times it is the reporting radiographer. And the key thing which is done is that it is mandatory to inform the original reporter. So it is mandatory that you have to tell the original reporter. This is done either by the submitter or the convener. And there is, of course, a buffer in the system where juniors are not involved. They just tell the convener, and the convener will say that this is what you have missed, and everybody takes it very positively. So that is the key thing to remember. And once the cases are submitted, then the conveners, what they do is that they anonymize the case to present in the meeting. Once again, a repetition that only submitter, original reporter, and convener know the identity of the patient. And now, lately, the new concept which has been added, which is a morale booster, are good spots. So sometimes there are subtle findings which were difficult to pick up, and somebody has picked up a special finding. We email it, and he or she is given a pat on the back. That's a good spot. So that is considered a morale booster. And this is after the meeting. What happens is that the consultants who are in charge, they make a document out of it. Usually in our department, they do a PowerPoint. At times, they do a Word document, and whoever has attended, it is added there. And this is how they do. For example, in this case, the discrepancy was that if you look carefully, this is the heart, and in the retrocardiac area where I'm pointing out, if you see, there is a geographical area of consolidation, and it was missed. And later on the CT, it was picked up. So what is the learning points? These are the headings: discrepancy details, and then type. It is a perception type. Learning action points. Remember to check behind the heart on a chest X-ray. It's a review area. So you see now how powerful is this method to learn, that from tomorrow onwards you see this case in the meeting, and it's a reminder for everybody that I will not miss whatever, it will be my review area, what is behind the heart. And please remember that the same case is an FRCR case. Same case is an FRCR case, where They will show you nodules or paravertebral masses, in the retrocardiac area. So this is what I say, the connection between FRCR and learning from your mistakes. So last few slides, we did a poll, uh, and many, about 237 people, they responded from all of these countries. And so we asked two questions, which were simple. And are you familiar with RCR's realm concept? And the response was that I think 46% they said yes, 53% did not know about the concept. So this is what this session is about. Try to tell you about this session, this concept. And and then we asked a question that, do you have a mechanism of learning from your mistakes? And interestingly, 56% said yes. So I will be very much interested to know more about it. What is that mechanism? And is it as robust as what we do? So this is a very interesting, figure for me. 56% say. Anecdotally speaking, many people email me or message me and things like that. And I think 100% of them said that we don't do anything. But 56% still think that they are doing something. So maybe that will be a reflection point. What they are doing, is it as robust or not, and things like that. And 43%, of course, say that they are not following anything. And then I asked people that, anybody of you who want to join us in the future. I've got a lot of things which, as we proceed, I will tell you how you can join and what we can do together and things like that. 9 people are very interested, which is a very good beginning for me. So one department in one country, if does something, I think they become a role model for more and more. And this is how ideas grow. So there are 9 people who with me now who want to be part of this project in the future. So thank you very much. This was all a repetition. So Ram, over to you, please.
Thank you, Dr. Khan, for that excellent talk and introduction. Can you hear me?
I can hear you. I can hear you loud and clear.
Thank you so much. So I'm just going to share my screen just to check everything is working. Okay. Share screen. Go to presentation mode.
We can see your notes type of format.
Yeah. How about now?
Now it's correct. Now it's fine.
Okay. Thank you, Dr. Khan, for the invitation, and also for all the colleagues who have joined from different parts of the world. I'm going to talk about, I'm sure Dr. Khan has inspired many of you, and many of you will get inspired in the future to set up a meeting. I just give some tips. It's like my personal experience over 14 years with the involvement, and also understanding different cultures over the years. So I'll just give some tips, and hopefully that's helpful. Before I delve into the subject, I just want to ask a question. I don't have access to the chat box, but what makes a great teacher? Just 1 or 2 minutes I just want to spend on this question. Please type in the chat box. I just don't have access to chat box. Somehow I can't see it, but
So I am looking at the chat box. I will read for you.
yes, please.
Your
Yeah.
question
Thanks,
is,
Dr. Khan.
what makes a great teacher? And one answer is there: inspire.
Inspire. Yeah. Keep going.
Loyalty to students.
Yeah.
Loyalty to students. Non-judgmental. A
Yeah.
good learner, open to learn at any stage, age. Patience.
Excellent. Yeah. I think
Passionate, open to learning.
passionate. Yeah. Brilliant. Yeah. I think very good
You
answers.
want me to keep reading or you want me to stop now?
You can read 3, 4, and then we can stop. Yeah.
Responsible, empathic, go to the level of students.
Yes. Yeah. Keep going, Dr. Khan. They are really good.
Please
Appreciate that.
continue.
Yeah. Okay.
Know the concerns of the students
Yeah.
and drive. So drive should be there
Yeah.
and approachable,
Yeah.
availability,
Yeah.
respectable. Sorry, what they mean is, I think that make you understand any topic.
Yeah. Super. Yeah. Okay. I'll thank you so much for that. I might have to copy those things. It's quite good answers. I just got this on a WhatsApp. Somebody sent it, and I think most these things that you all have already covered. Like dependable, build students' confidence, life-changing positive impacts, lifelong learners. I mean, teachers they've put it as they are learners. Okay. Now, I just want to put Dr. Khan's picture there. I think he would, in my view, would fit almost all the criteria you have written or whatever is written. And that when I saw this, first thing came to my mind was Dr. Khan. I was a student in 2012 and 2013. I went to Basilan course. I listened to all his lectures, and it was really a great experience. At that time, I wrote this feedback just to for people who are from India will understand this feedback better. Maybe few from Pakistan, cricket playing nations, but I just explained what I said at the time in the feedback was attending your session is like watching Sachin Tendulkar at his best and listening to A.R. Rahman's music at the same time. Now, these are two big legends in India, very humble people. They're really, when they're at that time, they are at their peak. They were, Rahman got Oscars, Sachin broke all the records. Sorry about people who don't know cricket, but that's a kind of a huge stars. And I was telling, it's a great pleasure listening to you. I almost, it's so enthralling. And inspired by his work, I always had that thought when I used to attend those sessions, I should someday teach. Definitely, I won't reach his stature, but again, so in Jan 2023, I started something called as Lifelong Learning in Radiology series. It's online free sessions. We get speakers from all over the country from 8:30 to 9 o'clock. It's open for everybody. We have several trainees from nationally joining and also overseas trainees joining. Thanks to Dr. Khan again. Since last his lecture on this, several from this audience have joined. I hope they are enjoying. And if anybody else wants to join, happy to join. Again, as I said, Dr. Khan was one of the main inspiration. I got a few more names there who kind of inspired me to develop this, and it's full credit to them than me. I know Priya, you know Priya, I suppose, from she has taught in this previously, so there are many people there whom you may not know. So if you're anybody interested, please email me. I'm quite happy to kind of share the invites as it goes. Now, one thing just to end this part of it is to, I'm sure Dr. Khan has inspired many people like me, not just me, who have gone on continued taken teaching. So you all have an opportunity. When you have an opportunity to teach somebody, please get involved. This quote I want to share: the best thing a human being can do is to help another human being know more. So you all will have that ability at some stage. Use those. You're already teaching, then that's great. If not, consider it. It's quite the best way you can pass on is to teach. And this is my friend who always used to tell me, if you teach, you will learn. And this is president of the Indian College of Radiology. His WhatsApp status says always teach equals learn. I thought it's quite interesting to put it there. After that brief kind of away from the topic, I thought I'll just move to the topic involved. So we'll just go through introduction to errors. Dr. Khan has covered quite nicely the last session and a brief summary of the last session. I'll just give few kind of little bit variations of this. It's not just about radiology. Everybody does mistakes. Healthcare is filled with mistakes. This particular study, a Mayo Clinic study, looked at the autopsies published. There is some 26% of the cases, there was a major diagnosis was missed clinically when they checked postmortem. So it's not just about us. It's a common problem in healthcare. And this is one old publication, 2013. It published in BMJ. It says medical errors is the third most common cause of death in the US. So it's a complex problem, affects everybody, all stakeholders. None of us go to work to do mistakes. We have to remember that. We all go to look after our patients. I'll give a moment again. Dr. Khan should help me with the chat box here. Have a look at this image, and can you, any of you, identify a hidden sign in this FedEx logo? Just take a moment and look at the. If you already know about it, keep quiet. But just to others to try. If you have known about this concept, just stay away from typing. But those who don't know, can you identify
Somebody has typed arrow, the word arrow.
Exactly. Very good. Well done. I hope you picked it up today. If not, that if it's not, basically, I'll show you now. Many must be wondering what was the hidden sign in this. So basically, this arrow, it is kept intentionally by the company. It's like it's a delivery company, so that is the arrow. Now, once you've seen it, it's very obvious. If you've not seen it, it's very difficult to identify it unless somebody points out. And then once you pick it up, whenever you see next time, it's quite easy to identify that. Now, the reason I'm saying is in context to radiology is we often, if you look at the cases missed or various type of cases we see, they're hidden in a scout image or the edge of an image, behind the heart, as Dr. Khan showed one case. So it's not once it is obvious, it becomes easy. How people will say, how easy? How did you miss that? When it becomes obvious, when things go bigger, and when you look back at the film, yeah, it is easy to identify it in hindsight. So that's the kind of concept I just want to say, that there's lots of things is in are hidden. Now moving on to a case, I just put in a case here. I'm going to go through more cases in the next talk, but just for this discussion. So this is my relative actually from a very remote part of India. He's 40-year-old, had a thymoid in 2018, and CT done to look for recurrence. This was in, I think, end of 2022, if I remember correctly. And in this CT, I'll scroll through the images, and you can see he had a full resection, and he was well until 2022, and where he started losing losing weight. So as you all can see, there is a large mass and its recurrence. And it was correctly reported as a recurrence. And then he was referred to tertiary center, which is a bit far away, and he had to make arrangements. And he was going back and forth for further investigations, whether to go chemo, radio, that pathways. Surgeons were a bit reluctant. However, when 3 weeks, I had a bit of idea. I asked them to send the images, but 3 weeks down the line, he started having a lot of back pain and paraplegia. And by the time I had the images, now they sent me the images. And then when I go now, it's interesting is what I really want to. I'm telling you, as things are, is there is a large mass here. This was not mentioned in the primary report. And by the time now it had gone, I mean, this is 3 weeks old scan already, and there is a paraspinal mass extending to the spinal canal, and it is compressing the cord. Now, I'm seeing the scan. If I tell
excuse me.
Yes, Dr.
Suddenly,
Yeah.
your voice is slightly breaking up. Now it's fine,
okay.
but if you whatever you were describing, it was slightly breaking up your voice.
Okay, I'll just repeat this.
Yeah.
So 3 weeks later, he was complaining of. Now you can hear Dr. Khan?
Yes, yes.
Yeah. So he had kind of symptoms of paraplegia, weakness in legs. So I got a chance to look at the images, and then said, okay, this is, yes, he needs an urgent MR spine and maybe radiotherapy. Now, this is the tricky bit, because in India, if I tell the relatives that this was missed, we don't know what the response will be. Sometimes they can get emotional. It's a different culture. And this may be the case in many countries. And we don't know whether they'll become very angry, upset. Sometimes, doctors get assaulted. It's a kind of very sensitive area. So I have to be very careful to the relative to say, I said, get the MR spine, get the treatment started. And then I didn't say about the missed pathology at that time. I said, I will tell them at a later stage when I meet them in person, because I know that can be misinterpreted and can go wrong how they react. So, as we saw in this case, mistakes have got consequences.
Sorry,
Equally, yes,
on our screen, we can see one bar which says app Zoom is sharing your screen. Stop sharing and hide. If you can hide it, can you hide
yeah,
it? Now it's fine.
yes, yeah,
Now it's fine.
okay.
Thank you.
Thank you, thank you, Dr. Khan. Yeah. So mistakes have got consequences, as we saw in this case, and also they're common. 3 to 5%. Targeted studies suggest even 15 to 17% error rate. And however, important to remember is mistakes does not equal to negligence. It's a very complex subject. It's not straightforward. When you have all the information, it becomes so obvious, so easy. I had the information of back pain. I was not reporting in the middle of 100 scans and distractions. I was at home looking at my relative scan with that history, so I picked it up very easily. So we have to be very careful about it. Every mistake cannot be negligent. It's not an excuse, but we should remember that it's not negligence. But equally, it's an opportunity to learn. For example, if you look at the whole of humankind history, we always have done mistakes, and many inventions have happened because of some mistakes. Some mistakes. Without mistakes, we wouldn't have invented penicillin, vaccines. All the inventions came after they were trying to do something, some mistakes happened, and they learned something. So without this kind of learning from mistakes, we wouldn't be here. Probably the humankind wouldn't have existed. So it's an opportunity to learn. Every mistake is an opportunity to learn, to make things better. So this is a key important point. Now, why should we discuss errors? Yeah, discussing and sharing them anonymously will help everyone to learn. That's the fundamental point. And I was speaking to Dr. Khan earlier today, and he is very passionate about it. And I was very happy to listen to him. And everybody can learn. Cognitive bias can develop if individuals are not informed of their errors. The problem here is, I think it's called Dunning-Kruger effect or something. If you don't tell people, what they will do is they will inherently believe that they're working safely and thereby continue to do the same mistakes again and again until they get into serious trouble. So at some stage, one may get into trouble. So it's important to kind of feedback to colleagues in a nice way so that they can check a few things and learn from them. If you don't share and learn, this can cause a lot of damage to the patient and us in the long run. It is challenging. Discussing mistakes, it has emotional impact, risk of reputation, guilt, all those things, fear of losing job, practice, especially several countries where private practice, there's competition in private practice. It's very difficult, somebody might use it to, improve their practice and kill your practice. It's all sorts of problems. So you just have to be careful how you deal with this. The old paper, again, this is kind of gives why mistakes happen. There are radiology specific causes and there are system specific. So there are quite a few. I'm not going to go into details. Just if you want to take a picture, that's absolutely fine. There's a paper. I put it at the bottom of the thing. You can take a photo of it, and the recording is there as well. Now, I just wanted to explain a concept called fallacy of single cause. This is the Stone Age practice of hunting for scapegoats. When things go wrong, people try to find this is wrong. It's always, especially with social media coming into picture, it has become even more horrible. Before people can really analyze what happened, people start making up stories. So this is called a single cause. So for any complex situation, there is never a single cause. It's always complex. But we are wired to trace like times, disasters back to individuals and stamp them responsible. It is very flawed and it's very dangerous. I put two pictures here, two unfortunate high profile cases in the UK. This is Dr. Selu and this is Baba Gaba. Both were arrested by police for healthcare errors and and they were called responsible. And eventually, both cases, I think, to large extent, were dismissed and found out there were a lot of system factors than individuals. So it is dangerous. If you see some error, somebody else's error, just don't immediately put the blame on one person. Look at it carefully. There's another concept I thought I'll just share from, I've taken it from this book called Art of Thinking Clearly by Rolf Double. It's a really good book to read, really small chapters. What it is we are very good at telling stories, human beings, drawing the bullseye around the arrow. What it means is, if something happens, like if somebody gets a really reaches success, they will start telling stories. I did this, I did this, I did this, and they draw circles around the arrow and they say, I hit the bullseye because I did this. Same thing when failures happen, people who are analyzing the mistakes start writing around the stories and say, this is the reason it is happening. It's not correct. People start trying around and then call it to hit the bullseye. No, you have to ask the right questions. You have to look at the system factors, look at hindsight and story bias. And we can learn from such events more if we take the right approach. Okay, so there's another book called Skin in the Game by Nasib Talib. He's an excellent writer. If anybody who are into stock market investing, some of his books are very highly recommended. But in life, philosophy, and lots of things, he writes really well. And he said about system factors on this point, we just didn't get better with our transportation safety, not just because of we are learning from errors alone, but this transportation general system improved, like better roads, traffic signals, driving license, following lanes, rules, speed limits. All those things contributed to the improvement. So there's a lot of system factors to be improved. And radiology, again, we have to look at training, communication, infrastructure, all those things. Now, moving to the next part of it, that's the brief introduction, just to share some concepts. If you're out to set up, understanding it is quite important. Otherwise, you may end up in having a wrong kind of setup and approach. So I thought I'll just share some how to approach it. Next part is learning from errors meeting. Dr. Khan again covered, I just not much to add for what he has said. It's an excellent opportunity to learn from mistakes, not just yours and others. It's pretty much standardized throughout the UK. Everybody kind of follows similar. We have a standards guideline. We use that as a structure. So if I come across a case, so for example, my relative's case I showed you, I'll first submit to my realm lead. We have a realm lead, and I'll submit. Similar to Basilan, we submit the case. I send an email with the details. He will anonymize the case. Sometimes has to change the story. He will collect all the cases, and in our monthly meeting, he will discuss for whatever the 10 cases time take. And then once it is, he issues the report, writes back to the reporter, and then we send another email with all anonymized, everything with the learning points. We also discuss good spots, excellent work. The key thing I want to say in the meeting, just in addition to what Dr. Khan has said, is so now the whole department is in the meeting generally. If it's an MSK case and if the realm lead tells few learning points for that case, the senior MSK colleagues add few points to that. They say, in this case, I've had some experience, do this, do that, technique. They add their wisdom. It's not just about that case. They'll talk about, there's another hospital who are doing better things, or, I've come in experience another case like this. So it's a very valuable. So people, like if it's a GI case, our GI radiologist gives some opinion. It's quite a lot that you can learn by actively engaging with everybody. Somebody had put in a chat box a question earlier about whether the cases are available for non-members. Unfortunately, it's not available. But the standards document is available for everybody. So if you want to set up a meeting, I would strongly recommend read through this document. You don't have to follow everything. I'll go to the top, explain again in the top tips, but whatever suits you, you can use from that one. To access RCR resources, I'll explain later in a slide. Now, coming to the last bit of the presentation, top tips. And this was the main theme of the presentation, so I just spent a little time on this one. These are again, there's a lot of overlap. First tip is, if you have to set up, make sure it is a no blame or shame environment. That's the important thing. Whoever it is, you've got to have that kind of approach. You have to embrace the errors will happen, and you have to encourage people to report. If you do not follow that rule, people will not engage. And you have to understand, as I explained, the causes of errors are complex. Blaming individuals makes it worse. People will not tell if you start blaming. They will hide, and it causes more problems. And more, if you look at the biggest disasters in the world, because people were scared to tell somebody. If you create that kind of work culture, people will not come out, and then cause more disasters. And if you learn from them, actually it improves, reduces future such events. And if you are to set up, I hope, as Dr. Khan said, 9 people have approached. I'm sure more and people will get more inspired as the time goes. Just to think in this way, that you have to put yourself in other shoes. If you were looking at somebody else's mistake, if you feel that it's going to hurt you, if you had done that mistake, it's going to hurt them as well. So put yourself in other shoes. That's kind of one key message I want to pass on. And if you create that good environment, it is a win-win situation for all. Reporters, in the hospitals you work, if you're a private practice, it's win-win for you. And your patients, it's a win-win model. It's one model where everybody is winning if you develop it correctly. Even I can guarantee in some, wherever places in my hometown, a couple of doctors got assaulted over the years for some pursued mistake and things like that. In the long run, if we achieve this, even patients will start respecting it. I hope that will happen, and they will realize, that if they understand the whole complexity of the errors, and doctors are trying their best to prevent them, I think that culture will also change. Next important is anonymous. If you really want to make it is anonymous, for example, I'll tell you, because the audience is so wide and practice is so wide and the cultures are different, I'm just going to say, like in India, I'm using, because I'm biased, because I'm from India, I grew up in India. There are corporate hospitals, government hospitals, charity hospitals, group of radiologists coming together and doing a practice. There are individual practice in a, they have their own practice, all sorts of things. If you have to develop it, it's going to be really challenging. You've got to keep it anonymous. You cannot tell Dr. Khan missed this case in front of anybody. That's the important thing. People will not engage. It just creates more in the society, divisions, everything. You just have to keep it anonymous, keep it sacrosanct. Whatever mode you use, it has to be really anonymous. The same slide again, which Dr. Khan showed, just keep it anonymous. Everything else, legal cases, they're all in the media. Once it gets, particularly in India, if media comes to know that there's some mistake, all the channels will be there because of the TRP ratings. And I'm on the record here. I might be criticized tomorrow by somebody, but that's the reality, and nobody will disagree with that. If somebody comes to know some mistake has happened, if the media comes to know, all the media channels will be at your doorstep, and that can be quite devastating. So if you are to set up in your country or place, think of, if you have similar challenges like what I said in India, be careful how you set up. That should not dissuade you from doing this good work, but just keep that in mind. Ground rules. Tip number 3. If you were to set up a meeting, have some ground rules. Say if you start a meeting when I started a few years ago as a realm lead, at the beginning I used to put this slide. My first slide used to be this. Here in the UK, when I was a realm lead in my department, I used to say, this is meant to be a learning exercise. Beware of hindsight bias, all the biases. This this meeting is not real world, because here you know that you're looking for some pathology. It's not real world. The real world is you're reporting, like the humbling case which Dr. Khan showed last time, where the blood was at the top. He wasn't going. He was called in to look at something else. He spent a lot of time on looking at that, and you're not actually. And mistakes happen in that kind of real world. This meeting is not real world. So people start. Sometimes you're shown a case. How can anybody miss that case? That should not be there. No degrading comments. Everybody should be respectful. And having said that, within UK, I can say over the 10 years or 15 years, the culture has changed. Previously, those things were happening here. So don't think that it is the perfect system. It has evolved over a long time. Um, uh, there used to be grading that has gone now. People don't talk any, at least in my department, nobody makes any, however obvious the mistake or whatever, look, the people be very respectful what they say, because it could be them. You have to put yourself in other shoes. And I have examples where people openly criticized. It happened to be their own case we were discussing. It was even more embarrassing. The people who were making lots of noise actually happened to be their own mistake. So just be careful. It could be you, or if not now, tomorrow. Please give. I always used to say, when now we don't put this slide. I mean, in my department, my two other colleagues run it, and it's really, they do it really much better than what I used to do. Give additional concept. We talked about it earlier. Be non-judgmental, and this meeting is not just about mistakes. Use the opportunity to submit some good spots. If you come across your colleague who's picked up something, you see, yeah, submit it, celebrate. That's, you can learn from them as well. Use the available resources. Now, I talked about briefly earlier this standards document. This is an excellent document. It is free for everybody. It is available. You don't have to be a member of the Royal College. And it has how to conduct a local learning from errors meeting or realm meeting. It gives you a very good idea. You don't have, we follow most of it. There is one we don't follow. So you can use it as you fit for your purpose. Just acts as a good guide for you to read through. It's a very well written document. Strongly recommend to read it. This is the future of the READ project. It's going to be more and more digital. The less and less newsletters. Again, you have to be a member. The college, I think, has reduced the membership fees for overseas participants. I think it's a reduced fee. If you can afford, and if your society or somebody can afford, then you can access those cases. So that's all under the, you have to log into as a member. There are lots of cases inside. There's going to be more digital cases going forward. Interactive bite-sized modules, questions, quiz questions. It's going to be more digital going forward, given the changes in the technology. And Dr. Khan mentioned earlier about this course. If you happen to come to UK for overseas trainees, overseas colleagues, if you have to attend one course in entire Europe, I'll tell you, I'm a bit biased. Attend this course. It happens in November every year. This year is in Cambridge. Dr. Khan is speaking every year in November. This is fantastic course, good value for money. If any of you are planning traveling to Europe, November is not the best time to travel to UK, I would say, especially from the sunny parts of the world. It's cold, short days, but this course is really good. The experts from different fields come and share about learning from mistakes. It's not just about radiology. Some big names I put there. So that's one, I would say, a good resource if you ever want to attend a course. It's the best course. Sorry, I don't have access to the chat box, but I'll take the questions at the end if that's okay. Unless a very pressing question, that's absolutely fine. Dr. Khan can interrupt me and ask a question. This is again now fantastic. I was very happy. Dr. Khan, I think, mentioned this somewhere.
Sorry, I just wanted to ask, your top tips talk, has
Yeah.
it ended?
No, not yet. Not yet.
Please continue, and then we will take few questions and maybe give them a break also.
Yes.
Please.
Yeah. Okay. Yeah. Another 10 minutes, I think it will go on. Yeah. Is that okay, Dr. Khan?
Please continue.
another 5
Don't
to 10
worry.
minutes. Yeah, thank
Don't
you.
worry.
So this is, I think, resource. I'm really happy because I've been a student of Dr. Khan. The passion with which he teaches, it's free for all. Everybody can attend. He's planning a lot of these sessions going forward. I think this is second session, if I understand correctly. There are a lot more sessions he's planning, so attend them, learn from him. He's going to get lots of speakers. Hopefully this will inspire a lot of people to do in your local setup and things like that. I felt very honored when he invited me. It's nice the teacher you most respect asks you to come and give a talk. It's unbelievably happy moment, and I'm very grateful for him. So this is will be a good resource. Please attend regularly whenever you can. I think you will learn a lot, and also you can start something. This is another resource I put, again, no advertisement or anything, free event. I have no conflict of interest. As I said, if I've got inspiration from Dr. Khan, I'm not going to charge anybody. I'm not going to you know ask, change or build anything in the future on this. I think you are welcome to join on a Friday morning, half an hour every Friday, most Fridays at least. If you email me, I'll send that. Okay. I'll invite you. I'll put you on the invitation links. Um, Patient safety. I put some websites. You can take a picture. These are, where you get very resources. I have a lot more. I didn't have time to put through. If I come back another time, I have some health issues, but maybe in a couple of months down the line, if Dr. Khan wants me again, I'll come and share some more resources. I just put few here. There are a lot of YouTube videos. Books. These are, if you want to take a snap of this, these are really, really good books. Many of them are decision making errors, how to improve. All these are really fantastic books. I would strongly recommend if you can read them. If you have read them, that's great. If you have not read them, worth having a copy and read them. That will help you. Now, tip number 5: one size does not fit all. I've briefly covered this topic here. In UK, what you have to understand is, the trainees who have attended from UK, you will know, our trainees are consultants. It is all uniform. It's very mature system. It is same. You go to Scotland or Southwest or anywhere across the country, it is the same system, same way of working, single NHS family. We all work similarly. Our images are shared similarly. Everything is so. It's much easy to develop a system like this. I cannot tell you how important thing to understand. If you are to set up in your wherever you are, say in Egypt or Nigeria or Iraq, it may be different. In India, I know it is for definitely different, and you got to work what suits you, your culture, the population, what the understanding, what kind of colleagues you have. It might take longer time. Even in UK, with such a mature single form of simple system, it took such a long time for this to evolve. So I can imagine it will be challenging. What I'm trying to say is, one size does not fit all. You got to adapt to what you feel will work for you, what won't work, and then slowly you can adapt as the changes have come in. So it's a quote I just put there. Tip number 6: you got to start. Somewhere you have to start. There are a number of ways you can start. You can start if you're working in a small city, say in, let's say, I'll take an just for Islamabad. Okay, you got to make friends, and you have to work together and see how you can develop something what suits your city, your people, your colleagues, your public. Um, if you work in a government or private house setup, it's much easier because you've got few radiologists, you've got a lot more imaging coming through, you've got a lot more interaction. You could start setup. One thing I want to say about the top one is we presented in Bangalore a couple of years ago. And that one of the audience stood up and said this. So when you teach, you learn a lot. The audience stood up after we presented about real and everything. He said is he was not asking a question. He was telling the audience. Is somebody from Lucknow, I think. We were joined online session. It was so he said to the audience, "Well, why don't we start in our monthly, they have a monthly radiologist meeting every month. They meet a CME. As part of CME, shall we not get one or two cases and discuss among ourselves? So you can, if you have a similar thing in a society within the city, you could try. If you have contacts in your local, regional, or national radiology societies, that will be best bet. You can start conversations with them. You can connect with them to Dr. Khan's teaching, my Friday teaching. I'm quite happy for them to join and kind of understand. Not, I mean, nothing is perfect. Neither I don't think I claim the Friday morning teaching will answer every questions, but just to give some resources, and you can start those conversations. You got to start. This is the last tip. If you want to start, you can start with good spots as well. Why not? Why only mistakes? You can learn a lot from good spots. You can learn a lot from good spots. Be genuine. Uh, just because I'll appreciate. Definitely, it's not. I'm appreciating Dr. Khan because he appreciated me. I have humongous respect. I'm sure all of you have the same feeling. So good spots should be genuine. Otherwise, it becomes really people trying to help one another. The purpose is lost. Be genuine. Do it with no expectations. Trainees and our reporting do pick up lots of great good spots, and we do nominate our trainees as well, and also radiographers. It's not just consultants. We nominate our trainees. I have a presentation only about trainee good spots. Again, when I get if there's an opportunity in the future, I'm happy to present just on good spots, one half an hour talk. Trainees can nominate your fellow. If you're a trainee, why don't you nominate your fellow trainee? Nothing stops you. So like that. So just a few things. Expressing appreciation is a positive force. It doesn't matter where you sit in the organization's chart, above, across, below. It helps everybody to feel appreciated, valued, and rewarded. And I've not put the reference. Sorry, I forgot to put the reference. This was one of the large study in USA, about 11,000 participants, and they came up with this comment called gratitude spillover effect. It's enormous. People who experience gratitude are more likely to feel happier, spread that happiness, increasing trust and collaboration among colleagues. So gratitude, that's important. In 5 minutes, I just want to finish up. So I've finished the top types of setting. I just want to share. I'm very lucky that I was part of this project. RCR allowed us when we shared myself and Priya in 2010 with the college 2011 time. They agreed and they allowed us to be part of it. Particularly thanks to Priya, who kind of uh, took all the kind of convincing part of it, and college agreed. And somewhere in 2015, I kind of thought I'm from India, so I was very keen. At least I could start with India as an experiment. So 2015, it took 7 years for us to get a platform. I don't know many people. I'm not very rich and famous in India. Very few radiologists I knew. They said, we are all from Karnataka, southern India. If when the national meeting happens in Bangalore, we will try to speak to the organizers and get them. So finally, we got it in 2021, but the COVID. So first they gave us half day. We did about 10 lectures about real concepts and everything in half day. Really well received. And I think college went to Dubai. Dr. Khan, I think, took Dr. John Smith to Karachi for a meeting, and realm was shared there. That was very well received. John Smith, our former chair, went to Caribbean to share with their society. I got invitation. I have a friend in Lahore, Shakat Khan Hospital. He said, "Can you share that?" I shared online with colleagues in Pakistan, meeting in Peshawar. It was very well received. We've been invited to give talks in various forums over the years. Again, we got one more coming up soon. This is just an example of how we did the session in Amritsar a few years ago. Like you can see the lectures about the real project, learning without shame, GI radiology pitfalls, common pitfalls, especially some speakers like Adrian Brady. If you Google his name, he has published extensively on errors. We were very fortunate. He was in Amritsar at that time. He gave a talk on errors. His expertise is errors. He gave a talk. We had an American speaker. We had a speaker from Singapore. So it was like a speakers from around the world, and it was very well received. This was some pictures there. Dr. Kath Halliday, our president of RCR, that's Dr. Adrian Brady, Dr. Kale, one of the Bangalore radiologists, who kind of main person who connected me to the big people in the Indian Radiology Society, like these people here, Dr. Anwar Rasu and Sikandar Sheikh. They are the president and vice president of the Indian College of Radiology. And just sharing, the feedback. I'll just run through a lot of positive feedbacks. Some people wrote like this, would like to start in their department, and they have started. Few of them, I can report that. This was the feedback from Peshawar Talk. So I just want to share some inspiration for to set up. If you are anybody in borderline, can we do it? Yes, you can do it. It will take time, effort. So this is what Dr. Khan had showed. Anuradha was working in NHS a few years ago, and she went back to India, and in the department, she wanted to set up something similar. She had seen it here, so obviously she wanted to set up. And she did face a lot of challenges initially, but eventually, if you see that, I'm glad to say that a few of our senior colleagues voluntarily report their own mistakes and platforms exemplifying the right culture. And that was fantastic feedback, I thought, of achievement. So I kind of put that there. So it can be done. It takes time, efforts. And similarly, whichever country you are in, there will be radiologists who are members of the college or who have worked in UK and gone back. They may be able to help you to set it up. So just speak to them. That's one other resource you could find locally. There are about 4,000 or 5,000 overseas members of the Royal College of Radiology. So they may have worked in UK for some time and returned back home, and they would have seen these things happening. And if you get in touch, they might help you to set it up. It might be a good idea. One more thing I just wanted to say is in India, again, this Dr. Anwar Rasu, so what they did, which is quite interesting, I thought, is, as I said, one size does not fit everybody. And these people wanted to start something kind of in India nationally. So they started something called as Pearl Project, Pitfalls, Errors, and Radiology Learnings. It's an Indian College of Radiology initiative. Now, what they've done is, because it's so complex to do similar to UK, what they've done is they mandated that there should be learning from error session in all the midterm CME conferences. They happen about 6 national conferences in a year, midterm CMEs they're called. All of them will have dedicated learning from error sessions. So that's a good start. I thought I'm sharing just in case if you want to replicate something in your own home countries. They also do something annual National Sono Summit conference. In that half day it's a 3-day conference. Half day is dedicated for learning from errors. They want to start a newsletter. They are collaborating with international societies like UK. We have been invited for 4 consecutive years now to go on. They give us half day to talk about errors. So that's one thing they're trying to collaborate and try to do these things. So that's a kind of a typical half day session they have on the Sono Summit. So I thought I'll share here because they're trying to fit what might be good is to educate them first before implementing. So they made it incorporated in about 8 conferences in a year. There will be learning from errors talks. So that's I think a great thing they have done. This project had a low impact locally, nationally, internationally. At least I know. So I think in Lahore also there is some sort of a LFM type meeting in the Shaukat Khanum. There is many centers in the world. They might be following. You can adapt to whatever suits you. And if these things are not inspired, I'm sure Dr. Khan's talks from now, what he has told in last and this, I'm very confident this will go to a new level for many parts of the world. And hopefully there will be, and as I said, it will be a platform for you. If you start a setup meeting, you have got few cases, you can come and present here. I am part of the RCR Real panel. I am negotiating if overseas members can submit cases. It's big discussion stage, but you can present here in this forum some cases so that we can learn as well. So there are huge benefits. Last but one slide, things. So learning from errors and good spots has got huge benefits. One, future less errors, better quality. We cannot eliminate completely. It will happen, but at least reduce them. Quality, better quality, less complaints, less legal issues, overall improved morale if you're talking good spots and stuff. and then better reputation for your organization, better patient experience. So there are huge multiple benefits from this kind of process. And finally, I want to thank Dr. Khan for allowing me to come here and share whatever I know. It's all a lot of it personal views and experience and sharing. Not that this is kind of drawn in, this is it. You have to do this way. There are many ways to do these things. So thanks for the team who are working behind the scenes. Always, it's good that Khan puts all your photos. It's really nice. And the final take-home points, uh, we have to accept that we all do mistakes. We have to be open for feedback and ideas to continue to improve. We have to create a system to share and learn. Discrepancy, error, opportunity, catalyst for change. As I said in the very beginning, and many trial and errors is what moves forward the humankind. So it's an opportunity. It's not a disaster. Discrepancy is not a disaster. It's an opportunity. Educate, share with colleagues where systems don't exist. If you have a system, then share with everybody. And I just want to end the quote with one of a great leader from India, Mahatma Gandhi, which said, "Be the change you wish to see in the world." I end that. Sorry, I must have gone over by 5 or 10 minutes. Sorry about that. I'll leave. Any questions? Please feel free to ask. I didn't have access to chat box, but I'll just start looking at it.
Brilliant, Ram. So what I was seeing with a lot of interest is that, as they say, a small seed here, a small plant here, tomorrow will become a tree, and the ideas. So you've done well because some of the departments, some of the societies back in India, they have started something, and you are absolutely right that one side does not fit all, and every their local environment can do that. So my message to the audience is that today, if you have got any idea, if you are from a radiological society of your country, or you want us to play something, some role, you want to ask or you want to connect with Ram, for example, or to our LFM project, please give us a feedback. In the feedback template will remain the same, whatever it is, but just write down wherever any other comment, just write down and write down your contact and your, whatever your vision is, and we can develop it there. My idea is that even in one country, if one department starts it gradually, if it needs so many years to start, gradually, it's a good thing. I think it should spread, and maybe one generation down the road, it would have spread everywhere. So, brilliant talk, very insightful. The chat is open. Any questions from your side? Any comments at this moment, Ram?
Uh, no, Dr. Khan, I think you summed up very well. I hope more and more people join your. The one word I forgot to mention is Dr. Khan will be a great ambassador for this work, and I'm sure you have a long, healthy life and build this up further. I think it will be great. Your kind of selfless passion is required for this to grow.
Yeah, so let me tell you, next session is totally different. Next one I have planned for because Dr. Khan's teaching is about FRCR exam. Next session will be like a regular potpourri type of a session, and the cases will be from this world, from the world of learning from mistakes. You will find it very interesting. Don't miss that one. And we will take Viva candidates, our usual format, and then I will tell you in great detail from each case what are the learning points and how you can learn. So don't miss the next session next week. That will be like our normal format.
Thank you, everybody. I'll go through
So,
the questions. There's nothing majorly I've seen, but I'll keep
Ram,
reading.
what you should do is give them a 5 minute break and,
Okay.
and look at the chat. And after the 5 minute break, you can continue with answering the question and then your second talk.
Okay. And the voice was okay after that, Dr. Khan? Just
Yeah,
checking.
there were at places, at times, there was a bit of issues, but we could make out. We could make out.
Okay. Okay. Yeah. Thank you. Thank you.
So this is a 5 minute break. After the 5 minute break, your questions, any relevant questions will be answered, and then the second talk will be there. And feel free to any comments, anything, even cannot be answered now. You can ask questions in the comment section of the feedback, which is a usual template. And if you want to connect with us, if you want to participate with us, just put in your contact also within the comments. So I'm going to switch off my video and mute myself for 5 minutes. Then we will open up. Thank you. Ram, you're with us?
Yes, Dr. Khan, can you hear me?
Yes, we can hear you. So over to you, if you want to answer any question. I think one of the question which I want you to comment on is, in a way, it is based on the cultural aspect which we were talking about. And look at this. In every hospital takes this, sir, not every hospital takes it positively, especially the local hospitals in Pakistan and in India and Middle East. Radiologists are being targeted, even reprimanded badly. Over to you, Ram.
Yeah, I think it is. Agree. It's a challenge. I mean, one of the reason I wanted to do it in India very passionately means very passionately because I know somebody who was assaulted by public, and that was the whole reason I thought, if doctors get assaulted, where to start? Should we start first from doctors, and then once we get the societies involved, the societies can talk to politicians and give public, use media and encourage. It takes time. At least first we should get the radiology societies and your local radiology society to talk to all this management. This is not right. It takes time. Again, it has to be. Individually, it is difficult. I can tell will be very difficult. But as a society, as a group of radiologists, your local medical association, everybody coming together, I don't know if that will work or not, but that's a good start, I would think.
One small step, isn't it?
Yeah.
Journey of 1,000 miles. So
Start with
that
one.
will be the
Yeah.
first step. So we do understand that what we are doing in UK, we are lucky in to be living in a totally different environment, and people in rest of the world they find it very challenging. We do understand that, but that doesn't mean that we need not learn from our mistakes. That's the
And if you
counter
try,
also.
you never know the results. That's the thing. We are all scared to take that first step. So often we are scared to take that first step. Speaking to some of the radiologists may be connected to politicians. If you get those radiologists on your side and explain, they may be in a position to talk to the management, politicians. It is, you have to use different ways in different places. Our behavior when I'm in India is slightly different than when I'm here. We got to adapt to the environment sometimes, and it is difficult. I agree, but you can try. Best would be having a good group association with strong ethics values. If you can develop that, that can inspire others, and people will eventually truth will come out that you are not wrong. But until that confidence comes, you have to work together collaboratively, try to find some way to find a way to communicate with these managements who don't understand. A lot of private sector, especially, it's money driven. They want to put in the website. I hope I won't get in trouble. I don't care. In India, I've seen some corporate hospitals claim so much on their websites, untrue things sometimes. Not everybody, but some. They want to build a brand reputation, which is fine, but don't tell lies. That's the thing. So and I'm sure their culture might be like very stringent there. If something goes wrong, they'll scapegoat or put people into trouble. That's where I think radiology societies, associations, these things come in very handy, I would imagine.
Right. One thing which I have reflected is that I was very recently, I was telling you in a conference in Greece, and there was a prof who came from Harvard. And he is a big man because interestingly, he is the chair of the hospital also. So he's a radiologist, but chair of the
So,
hospital. He did a brilliant lecture on anatomy of the. And in his talk, he showed two of his mistakes. Can you imagine? Can you imagine? So he's maybe one of the biggest guys. And then to my what we call uh, pleasant another pleasant point was that one of the guys presented. He was from UK. He presented a talk. Again, these were top people in the world. We read their books, and he presented one of his mistakes.
that's good.
This is what I call role modeling. Role
Yes,
model.
yes,
This culture that everybody can make mistakes.
yes,
But the problem is that in Harvard or in UK, we are protected by the system, and we see that people in every part of the world are not like that. Now, somebody has put in the chat that our silly mistakes spread like wildfires. Gagan, you are which part of the world? Maybe India you were talking about? Become a talking point. But, anonymization, why you have used the word Gagan in chat? I'm talking to Gagan Wahi, that our silly mistakes spread like wildfires. Should not they be anonymized? Everybody should not know who has done the mistake. It's a group mistake, isn't it? So, in any case, Ram, what are your comments on this?
yes. The thing is, ours is in black and white, Gagan. I agree. Everything is in black and white. If all the consultations are done with video recording, all the clinical, say, if a clinician opens an abdomen and he does some mistake there and he closes it, nobody will know. There's no record of it. He can come and say it was very difficult, a lot of things, and we can cover it up the mistakes. Even if he has damaged something, he may able to repair, close it. How difficult to prove that he did something. But for us, everything is in black and white. That is the big education we have to give it to clinicians. One of the talk I presented to respiratory trainees this time. I volunteered this time. They asked me to present on something. I said I will present one, but I want to present another one. And what I volunteered to do is, how will you tell patients when you see a radiology mistake? So I gave a full talk on, and this is one talk I want to develop and share with more our trust-wide clinicians. Be mindful. This is very complex subject. Just don't say radiologists miss this, and that's it. Our career, everything is in line now. So that's one thing. Educating clinicians. See, ours is in black and white. Yours is not. There's a big difference. Hindsight bias. When cancer becomes big, when you look back, you're going to find a small nodule, and I'm guaranteed you'll find a nodule. Prospectively, if you give it that nodule, many people might miss it. But when you got big mass, our eyes will go back exactly to that point, straight searching for it. So this is hindsight bias and outcome bias. If you miss that nodule 10 years down the line, if the nodule has not changed, our reaction is different. The mistake is same. We missed nodule in both cases. One became big cancer, and now our reaction is, oh, it's cancer, he's dying. Missing nodule sometimes is a difficult topic. I've got few cases of nodules and everything. I mean, as I said, if the, I will be more than happy to come back at another time. I've got few ready talks to share here, but just I need some 3 to 6 months time just to recover from what I'm having personal issues at the moment. I'll show some nodule
Excellent.
cases, some outcomes.
Sure,
Go
we
on.
will love to, and we, because it's going to be an ongoing thing. I want to
Yeah.
continue with this every few. It all depends on how we want to tackle it. I will personally, as I'm talking to the audience now, I will personally share with you cases, my usual style, because what are the learning points. But we will definitely invite experts like Ram on various subjects. One thing which is encouraging me that you people are participating in this conversation. So at least that's a success. And we understand that the problems at your end. Gagan, point taken. I have read your points, so thank you very much. And Mr. Moses from Zambia, great. Uh, in the comment box, please share your ideas, your what we call contact. I will contact you, and should I say we should work something together. I'll like to know more about Zambia and how can you do things there. And please share with me today in the comment section. So should we? It's good that at least we have a conversation. I think that's good, and we have acknowledged that there are problems in various parts of the world, and that is what the message was. Every size does not fit everybody, but that does not mean that you should not learn from your mistakes. So that is the counter. So with that, Ram, over to you for your second talk, please.
Yes, yeah. I'll start sharing screen, Dr. Khan. Yeah. So you should have the screen presentation mode. And display settings.
If you can hide that button, we are still looking at
Yes,
that
yes,
button.
yes, yeah. Thank you. Before I start again, for Gagan, I just missed one point. When I spoke to respiratory physicians, the trainees, their feedback was very good. Oh, we were not aware of such complexity. So there's a huge requirement now. I don't know how far the college will allow me to work. Is my one of the biggest ambition I have is to educate clinicians to understand these complexities of the errors, because they are important part of this. So that's the next. I don't know whether I'll succeed or not, but I voluntarily did one experimental talk, and the feedback was really positive. They said, "Good, you shared with us. Now we understand some things." So there is an element we got to educate our clinical colleagues as well at some stage that this is a problem. Okay, sorry, I'll just thought I'll add that point. Okay, moving
Recording
to the second
stopped.
talk. So the second talk is about case based. Let's assume we are in a real meeting. All of us are sitting. Again, I don't have chat box. If Dr. Khan can help me with the chat
Regarding,
box when I do. Hello.
sorry, you wanted me to do what about the chat box?
Just keep an eye on it, Dr. Khan. Yeah.
I will. I will.
I'll ask somewhere some questions.
The
If we
recording
can.
has been stopped intentionally. Somebody was asking.
Yes, yeah. Thank you. Yeah, that's.
We have stopped it intentionally. Please continue,
Yeah.
Ram. Yeah.
Thank you. So the ground rules, if you were to set up, have this slide ready and put it on before you start the meeting. So we're just going to go through some cases. Typically, if I were to be leading the meeting, how I go through. So I just put this slide out to remind, mainly, please don't grade this easy case, difficult case. How did somebody miss any casual comments? It will hurt people. People will know sometimes that, oh, this is the case. It vaguely remember I must have been involved, and it's just not a good culture in the team. So just have that kind of ground rules when. So case number one, the history given is shortness of breath and question mark is PE. Now I'll scroll through the images. So this was correctly reported as no PE and verified. Now I'll just scroll through the images and then back and forth and see if anybody points out anything. On the chart backs, please write. Okay, sorry. Just going back again to the same slices. no PE, correctly reported as no PE and verified. Anybody spotted anything else? Just a little
So
interactive
people have
exercise.
said thyroid tumor,
Very good.
mass, thyroid
Very good.
malignancy.
Very good. Yeah.
Yeah.
So this mass was not mentioned. But the point here I want to make here is it looks so big and it's missed. And it's not the right, as I said, we are now constantly know something is interesting in this case, and I'm giving a clue that there's no PE. Now this scan was done at 3 o'clock in the morning, and the reporter probably was focused just on the PE, and there were many scans to report, and that time of the day we are not kind of focusing so much. And it was picked up luckily next few days down the line, because the clinician came back and said there is some hoarseness or something, and then somebody looked at it and then it said yes. So it's basically a good example of a satisfaction of search. You look for PE, there's no PE, verify. And this is an edge of the scan image. So if you see, the pathology is at the edge, and it's a common recurring theme in our L meetings. Edge, the very beginning, or CT abdo-pelvis, we forget to miss the lung bases. Uh, I mean, FRCR teaching traditionally, we are very good at looking at behind the heart, behind this, behind that, behind this. For exam, to be exam practice, we do so well. But the same thing applies for the CTs and the MRs and everything. Look at the scouts, look at the edges, look at different sequences, look at all the things apply for cross sectional as well. And the important thing to remember is large data sets, and increasing workflow time, distractions, and tunnel vision to answer the clinical question. And that's all kind of learning points from this case. So these are the kind of, and sometimes clinicians, when we discuss such a case, my colleagues might add 1 or 2 points. So those are the learning points from that case. Okay. Any questions for that case?
So somebody has asked, was it a laryngeal tumor or a thyroid tumor? And I think you have
Laryngeal
answered,
tumor, I
but if you
think.
can elaborate again.
I think it was laryngeal tumor. It's a laryngeal cancer, yeah. So that image you can see there. Okay. Moving on to the next case. This history given is progressive fatigue, reduced oral intake, and weight loss, admitted with hyponatremia. Now, watch carefully with the history given. This is one of the important learning point in this is in the history. Now, the question is exclude malignancy. The reporter spends hours, and I mean not hours, chest abdo-pelvis, no cancer. You cannot see any cancer, and there's clear like hyponatremia. There must be something. Then finally it comes to this kidney, and he sees there is some loss of. These are JPEG images, so resolution is not quite good, but I'll try to explain. So there is a reduced corticomedullary differentiation, or that is loss. You can see the cortex better, and this is lost. And the reporter, for some reason, kind of on that day thought and called it renal lymphoma. It be in a differential, one of the differential, as is the left kidney looks infiltrative, loss of differentiation. Can this be renal lymphoma? Again, don't judge the report. Again, these things happen. It's real life. They were looking for cancer. So patient went down to hematology. They went to hematologist. They said, okay, we can't give chemo. We need a tissue sample. Can you do a tissue sample? So patient came for biopsy. And the biopsy was uneventful, but in the night, patient returned to the hospital with severe hemorrhage. Luckily, he was embolized and he survived and he recovered fully. And the pathology came as pyelonephritis. Now we know outcome. Now it's very easy to go back and say, oh, well, that wouldn't have called lymphoma, wouldn't have called. Now, history. They never mentioned the patient was admitted with UTI, urinary tract infection. If that information was there, we are very prone for interpretational errors, because if they give the right history, sometimes abscess will look like tumor will look like abscess. It's all kind of thing in kidney, which is unusual, and that was not given. With this info, the most likely differential for the was pyelonephritis, but the information was not there. And most would have said we'll do a follow-up CT, and definitely not a biopsy. But in this case, it was called lymphoma because there was a strong history directing the radiologist towards a cancer, hyponatremia, weight loss, everything. again, I just talked about the history. So that's the key learning points from this case. We have to educate our clinicians. Again, for that Gagan's questions, I know why he was so passionate about those questions. You got to educate your clinician in every opportunity. Build the trust first and say, give us the correct information. If you throw rubbish at us, you'll get rubbish reports. Learning points. Again, common things first. Again, few things we can learn. It's not that everything we should blame others. Pyelonephritis is far more common than renal lymphoma. So always think when you're making a rare diagnosis, just be careful. Isolated primary renal lymphoma is very rare in the absence of systemic lymphoma. If you're making a rare diagnosis, think twice. Clinical information may guide, but sometimes it can blind you. It's very important. Okay, just awareness that it can be a rubbish clinical history. I should work on what are the common things. Ask a colleague, get a neuroradiologist in your department to have a second look, something like that. Case number 3. This is something like the last, the bleeding case which Dr. Khan had shown in the first session DKT series. So we published one coroner themed edition. So when cases in UK, when patients die, it goes to coroner's court. And coroner will call everybody involved, radiologists are involved, and we have to go there and give a statement with the public. It's like a court, a mini court. The coroner asks lots of questions. The basically relatives want to know what exactly happened, why the patient died, and why you want. So there are a number of reasons that can happen where where a patient can die, and coroner wants to miss some pathology, because of terminal cancer, patient died later, whatever it is, as a complication. From that, I've taken one case. It's an elderly patient. Clinical information given us head injury on anticoagulation. One of my fellow panel member gave this case for publication at the time. So this was CT head was done for head injury, and it was reported as normal. In the middle of the night, it was done. It was reported as normal. Patient was discharged from A&E because nowadays clinicians are very much reliant on radiology. That makes it sometimes tricky. We say normal, they'll discharge. Sometimes, patient represented 3 days later with a large extraaxial hemorrhage. Patient very unwell, midline shift, and patient unfortunately died. And then when you look back onto the primary scan, and if you window it correctly, you see there is a subtle blood there, subtle right subdural. And I must say, I have missed something like that in the past. I must myself. So I don't want to kind of. I want to admit something like that. And we keep saying some things. Increasingly, we have realized in the latest we are not missing so many, because so many cases over the years were repeatedly. We are frequently learning points are basically have the correct windows. Always check for blood in the correct windows. Look for multiplanar review, especially corneal plane helps. Especially at the skull base, petrous ridge, orbital roof. This should be reviewed with extreme care. If you miss a blood, especially patient who is on warfarin or something comes with head injury, and if he miss blood, he continues to take warfarin, bang, he will bleed more and likely to die. And luckily, or whatever, in the good faith of the family relatives, the wishes of the family members of the deceased patient generously requested that we share any lessons learned from the event, and hope this will prevent similar events in the future. And I hope one day in the country I grow, in my own country, we will come to that stage, or many parts of the world, if that culture is not there. I'm sure there are a lot of good people everywhere, and if correctly they're given the information, not in a very emotionally charged way, hopefully many patients in many parts of the world will come to this kind of conclusion and say, okay, doctor, you did everything. Sure, such good things have happened
Ram,
everywhere as well. We don't need country. Yeah.
Just a comments about this case.
Yeah.
So I've got a lot of experience in going to the coroner's court for my hospital. So I've been there many a times. This particular case, missed subdural. In my experience, in my teaching files, there are 4 examples in the last about 14 years. 4 examples in my hospital.
Yeah.
And the last one was only about 2 years or 3 years ago. So I went to the coroner court for that. It was not my mistake. I was an expert there.
Yeah.
So you are absolutely absolutely right. Many patients, they say they get that closure by this thing that what have you learned? They ask you, and which is
Yeah.
something very good. And here, what intervention we suggested, and that we should make the subdural window as a mandatory template window. And in our department now, what happens? Automatically, a subdural window goes on PACS. Can you imagine? Every
Excellent.
CT, a
Excellent.
subdural window goes automatically. And this is so I think 4 cases in 12 years or something was too
Yeah.
much. And this was an idea of Azhar, actually, our registrar. He gave us this idea. And in the court, they really, they really appreciated that. So
Excellent.
now it's a sort of a reminder for everybody that look at the subwindow window. So now it comes as a default, in
Excellent.
addition to the brain window as well as the
Yeah.
bone window.
Super.
Over to
Thank you,
you.
Dr. Khan. Something to learn. Yeah, that's a really great idea. So this purpose of these meetings is this: you learn something new, you something make it better, reduce the chance of this event happening. Thank you, Dr. Khan, for sharing. That's really good. I might ask my colleagues to see if they can implement that. Yeah. Sorry, you were saying something else. Can you hear me, Dr. Khan?
No, nothing at my end. Please continue. Please continue.
Okay, okay. Thank you. Yeah, that was a good suggestion. Now, case 4. History of fall, low back pain. Again, you have to follow carefully the journey of this patient. So the plain films was done, and I think, if I remember correctly, the wedge fracture of the T12 was mentioned. Anybody spot anything else? Angst spondylitis was mentioned. Anybody spot anything? Chat box, please.
So we are waiting for any other Hawkeye radiologist to give comments. Anything else?
Angst and T12 wedge fracture was mentioned. Anything else you can see?
Pars
I'm
defect,
just running
somebody.
it like a typical realm meeting, how we do in our department. So just to give an example, just to
Okay,
people
dagger
engage.
extension, teardrop, half stick fracture, aortic valve calcification, chalk fracture, L1 fracture,
Yes, yes, very good.
cortical
Okay,
step L1, cortical step, somebody has said.
yes. So can you see my arrow, everybody? I think you are referring to this one, right?
Yes, I can see your arrow. I can
Yeah.
see. Yeah.
So there is a step there. Very good. Anything else anybody spotted? So look at the disk spaces. So disk space, disk space, disk space, and the disk space here is gone. Now, again, this is a very artificial meeting. We know we're actually looking magnified images. I've cut them images to kind of that, and it's all sorts of things, just to make it. In real life, it is not like this. And then the CTAs and no fracture was mentioned, and CT was requested. The clinicians said, let's do the CT. The CT was done. And CT mentioned there is discontinuity of the Angstpon was mentioned. This was mention of discontinuity of the longitudinal ligament. So clinicians' interpretation again here, what we say, what they understand is different. They thought probably there is no fracture. The description of the report said something like discontinuity of this and calcification of anterior ligament at level. MRI was suggested. But unfortunately, the MRI didn't happen for a few reasons, for a few days, and it happened quite 3-4 days later. And now, when the MR happened, that everything is now available. Now you have a good 3-compartment fracture, unstable injury, and that's the case. So I'll go to one companion case because it's such an important topic and so much detail. Mechanical fall, pain on movement, painful lumbar spine, and known ankle. This was a very comprehensive history. Known expon, pain on movement, painful lumbar spine, mechanical fall this morning. Anybody spot anything in this? It's a difficult one, really difficult one, but we can learn. Any comments, Dr. Khan?
So L4, L5, somebody has said.
L4, L5 is okay. Yeah, that's okay.
Somebody said L2, L3,
5, 4,
wedging, L4, L5, L5 fracture, and another one.
5, 4, 3, 2. No. It is very difficult. If somebody had put up, I would have put the good spat of the century. So we'll move on. So go
S1
on, sir.
fracture, chop,
Sorry.
T12, L1.
Excellent. So
Posterior
very edge. If you look at this one, this is a really great case for that because it's at the very edge of the film. You see, it's so continuous here. Yeah, and here we miss out, and there is a little bit at the very edge that pathology is there, but it's a significant pathology. So,
By the way,
yeah.
somebody has picked it up. Excuse
Okay, yeah,
me, Ram, I
well
forgot
done.
to see somebody increased disk space T12 L1. Are the comments. Well done. Well done.
Excellent. At the very edge of the film, it was there. So that was the CT done, and that's the fracture. So what can we learn from these two cases? So important thing is incidence of spinal fractures in a fused spine or angstbound is far higher than the background population. When a patient with AS presents with trauma or back pain, they should be considered to have spinal fracture until proven otherwise. It's so important. If you see an AS, just be extra cautious. If it's fused spine, they are prone for injuries. Low threshold to do a CT and an MRI spine. Also important early communication with clinical teams. If you see angstbound and if any doubt, pick up the phone and tell them I'm worried because it's an unstable injury. It's a relative point of weakness. The disc is a weakness and fracture can go through that one. And it's one of the most common sites to fracture at the disc space level. And this awareness needs to be improved not only at radiologists, but at multiple levels. Clinicians also, a lot of emergency doctors, many junior doctors are not aware. If the patient with angstbound presents to A&E with small injury, they might say painkillers and send them home. Even the clinicians needs education. Lots of clinicians, emergency physicians, junior doctors, that level of education is required. And we have to be very careful while transferring the patients from bar to the scanner, all those things. You don't know because it's an unstable injury. You just have to be careful on that one. By the way, we published this in the latest real newsletter, which is part of the news magazine. So, who are all members, they would have received the Wave magazine now, which has this case. No, the cases are not belong to me, but the educational points have taken it from there, which I edited. So, just given the reference at the bottom. Any
Excuse me,
questions on
Ram,
that
can you
case?
show the case again? Excuse me. They want you to show the finding once again, original case. The plain film.
Yeah.
There you
So
are.
that
Can you point out to?
so this line is so continuous. Here we lose out. See that? And that's it's. I wouldn't call it as a miss at all. It's a if somebody had picked it up, it would have been a very good spot. But equally, what I want to learn from this case is when you see a fused spine, give that extra attention. Keep searching. In doubt, if somebody calls me for a CT, without hesitation, do it. Don't argue with the clinicians. I mean, most places in the world, like India, clinicians are something, it gets done. In UK, we have to vet because we have finite resources. We tend to reject some of the cases. So it's very much, sometimes that can happen. Somebody saying, no, we don't want to do it. Nothing wrong there. Don't miss that one. A patient can end up paraplegic if it missed. Happy? So that's their pathologies. Okay.
Yes, they are happy. Please go to your next case.
Okay. So case 6, 40-year-old with upper GI bleeding, and this chest X-ray was done. Again, chat box. Sorry, Dr. Khan. Next time I'll prepare better with the chat box somehow. Anybody can point out anything. Just put it in the chat box, please. Let's see if I can join with my mobile Zoom.
So I'm waiting. Pneumomediastinum, somebody has said. Retrocardiac, somebody has said. pneumomediastinum retrocardiac. I think they mean something is there. There is a retrocardiac lucency.
Okay.
This that's behind the heart. Pneumomediastinum. I'm reading the answers.
Yes, yes. Pneumomestum, very, very good pickup. Well done.
Oval shape lucency behind the heart. Pneumomediastinum, another one.
Excellent. Good FRCR case, this one. So, what was the history given? I said upper GI bleeding. Can anybody put everything together now? It will be like a gold medal case.
Esophageal perforation. They have written
Very good. Why is the perforation happened?
Boerhaave syndrome. Boerhaave, another one, Boerhaave.
Very good. I'll give 7.5. Very good. Yeah, very good. So I'll go through the case. So this is upper GI bleed. Even today, where centers where there is no endoscopy services, they transfer these patients putting through Sengstaken tube as a temporary measure. So this is Sengstaken tube. This oval opacity is the gastric balloon, which unfortunately inflated in the esophagus. Sometimes these patients are vomiting so much blood, difficult to put things, tubes and everything. So this was inflated in the esophagus. So what that has caused is esophageal rupture. Burhouse is a good suggestion, but this was because of this. I think we can never tell what caused esophageal tear, but this was inflated, and there is a pneumomediastinum. So this is the gastric balloon, which should be inflated here, is inflated here. So I'll just draw the line. So that's the gastric balloon which is inflated there. That's the pneumomediastinum. Very well done picking it up. So this case, what learning points are is whenever you see a line, so first identify what it is, what line it is, from calling the clinicians. The lines are used to save or support life, but if they are incorrectly placed, these can be fatal. Whenever you see a line on the film, that means first thing your light bulb moment is, or you have to start thinking is, patient is ill. That's why he has got a line, and they're trying to save his life by putting lots of lines. 3 questions you have to ask: what is the line? Is it correctly placed, or any complications? If you have this kind of approach for every line you see, very unlikely you will miss anything. So, what is the line? First question: is it correctly placed? It's in the wrong place, and then any complications. So, remember those 3 lines, 3 learning points. Any questions for this case? Anyone?
So, what, so it is iatrogenic, and of course, it is.
Join my mobile, it's calling noise. Any questions, Dr. Khan?
So the question is that, but sir, second tube can inflated in the esophagus for varicosity. What happened with this line again? I don't know what exactly is the question. Sorry.
Shall we look at it at the end? We'll go to a few cases and then come back.
Yeah. Basically, can you just tell the audience what is the usual role of this tube, and what are the?
So before transferring the patient, you want to endoscopy. They do injection of sclerosants, but if the endoscopy services is not there in the hospital, they use Sungstaken Blackmore tube through the esophagus. It has got a gastric balloon and a esophageal balloon, and they inflate that balloon to keep the you know all the the varices stretched as a pressure tactic, and to stop the bleeding. So stabilize the patient and then transfer the patient. In this case, we will never know whether it was a Burhoff syndrome caused pneumothenum or this uh, gastric balloon inflated in the chest causing the esophageal tear, which we'll never be able to tell. But this patient had esophageal tear and pneumomediastinum. Okay. If you Google Sangstaken Blackmore tube, you'll get some images, and then you can correlate to this. In another presentation, I have that as a learning point. I should have put it, but I thought somehow not put that one here. Happy?
Yes, please carry on.
Okay. This is a case with GI bleed and CT angiogram to try to establish the source of bleeding. Now, this was done to rule out any cause for bleeding. So this CT, I'll go through the images, and if anybody spot anything, please point out. Just it's not the real life, but try to see any site of bleeding, please, or anything abnormal. Sorry, the answer came off. So I'll just, probably most of you read the answer there.
So people have said para-aortic
Paralytic?
soft tissue.
Yes, yeah, very good.
Soft tissue.
So there was no, sometimes when these cases come, our eyes are searching for bleeding point in the bowels. Like we keep on searching, we don't find any high density, nothing. And here there was nothing kind of active bleeding site. And probably that's why the reporter lost concentration there and missed that didn't report. It can happen to anybody. And there was this soft tissue paraesophageal, and that was actually a entero aortic fistula, which is one of those rare complications. So that was an enteroaortic fistula case, which subsequently kept on vomiting. I think he had another scan at the time it was picked up. Because if he's not bleeding at the time of scanning, we sometimes miss that contrast uh, uh, extravasation. So this learning point is, this is one thing to be aware. When you're looking for bleeding, we just look for, bowel lumens and site for bleeding and this and that, like duodenal artery or colonic vessels or somewhere, but think about a fistulas as a potential source of bleeding, especially if they had an aortic surgery in the past. That increases the risk of aortoaortic fistulas. Any questions for that case? Not many more cases remaining. Last three cases and then.
Commented about the diagnosis. Okay, so the question is how to confirm the diagnosis?
Okay. To be honest, I don't know. I really don't know. Suppose angiogram will help, like a vascular angiogram in the fluoro unit, put some contrast and see actively, you can see dynamically at the time going through if there's a leak. I suppose that is one way. If you can reach through endoscope, you may be able to see blood coming from that location. Don't know, to be honest. Any ideas, Dr. Khan, or anybody else in the audience?
Can I answer that?
Yeah.
In our department, we have got a very robust IR service, and plus a classical thing for day, as you have also answered. And I think if the service is not
Dr. Khan, I can't hear you.
You cannot hear me?
Now I can hear you. Yeah. It was breaking up a lot.
In our department, we have got a very robust 24/7 IR service, and these will immediately go for them. They will do, of course, a DSA and then whatever intervention is needed. And I think if in a department that is not available, I'm just talking about UK here, so you will transfer it to a department where it is, but this is a classical case where you need intervention.
Thank you. Okay, moving on to the next case. This was the history given, non-healing ulcer, left shin, MRI of the lower limbs was done to check for ischemia. Again, I've put some select images. If you can, anybody see anything, just shout out. I think we're shifting to answers very quickly. Okay. Anybody spotted anything?
Something in liver.
Excellent. Yeah. Very good. You're all really good radiologists. Yeah. So that's, these are scout images I put. So it was at the very edge there in the liver. again, when you're looking for, MRA, you're spending so much time on looking at the vessels, and sometimes we forget the scouts. So this was in the scout. So always make it a habit to review all scout images.
You should be, sorry, you should be, I think, generous enough to say that it is a good sport. You are being.
Yes, yes.
Did you hear me? Did you hear me?
No, I heard you. Yeah, it's a
No.
really good spot. Yeah, yeah,
Yeah, good sport. Well done. Well done.
yeah. So moving on to the case number 9. Uh, this was published in 2014 in our real newsletters. I always use this in various presentations because it's a very tragic case. People who do interventional radiology, for them. So this is a real case which was published at the time. Child with cerebral AVM required embolization. And the reason I put it is how the practice, one event nationally can change the practice. One event, you can learn so much from that and you can change the practice nationally. So this child with cerebral AV malformation required embolization. So previously had 5 marriages and undergone a successful embolization in the past on each occasion without complications. This time she came. A syringe containing glue was mistaken for contrast, and it was injected into cerebral artery because you're constantly checking your vessels and everything with contrast. A glue was taken, whether it was handed to him by the nurse, we don't know, was injected by mistaken for contrast, and a large amount of glue went in, and that resulted in the patient, as the lawyers described, as a catastrophic and permanent brain damage. Prior to the incident, she had been a keen dancer and wanted to become a doctor, but now permanently paralyzed, wheelchair bound, has lots of problems, and a big multi-million pound settlement was agreed. Now, the reason I'm saying this kind of moving case, how it can change, learning from this, it is there in public, and we published this case. We had published 3 cases as part of it because of the interest of time, of just similar kind of pattern happening at the similar time in different centers. So that's the advantage having a national collaboration. Something happening in, say, Delhi, or international collaboration, something happening in Karachi, something. That's why airline industry is so good. If an accident happens in America, uh, whatever may be the political situation, the airline industry in India will get the lessons from America, or Pakistan will get lessons, or from African countries will get lessons. So that's the beauty about airline industry. We do not have that much in healthcare yet. So here nationally, this was shared with an alert issued by the British Society of Interventional Radiology. They issued an alert, and we published in newsletters as well to increase that. So basically, what they suggested, a few ideas how to prevent it. You're in a lot of stress doing the procedure. Somebody injected, another case was chlorhexidine was injected, confusing for contrast. Because you're working in a dark environment, sometimes you don't know the chlorhexidine was drawn because chlorhexidine solutions used to be kept in IR rooms to scrub or clean up things. So somebody inadvertently drawn chlorhexidine and they're put in pots, chlorhexidine contrast. Somebody drawn chlorhexidine and injected, and the patient went on to have an amputation. So from then onwards, these learning points were shaped. Instead of solution, use a chlorhexidine brush to clean. Simple, okay? Permanently, that error will never happen again. You will never draw that. Use closed systems. Use separate trolleys for contrast and others like glue, thrombin. Keep it separate, 2 trolleys. So if you go to a typical IR center anywhere in the UK, when you go, you have 2 centers. So this came because of these cases. So that's the beauty of learning and sharing. So that's why I put this one. If you put in YouTube called Gina's Tragedy, it's a great resource to learn. It's about a half-an-hour video worth watching. It is really good. It's called Gina's Tragedy, and those are the learning points. Any questions of that case?
So I think there is a comment, syringes should be labeled or filled at spot. I don't know if it is a question or it is a comment.
Probably a comment. Yeah. I mean, I don't do IR myself. I think it's a comment, but if you go to BSR website and look for alerts and things, it's there. They've given clear guidance, and that's what is followed in UK. Separate trolleys.
So
Maybe they
it has
label it as well.
this is a suggestion.
Yeah, okay. Yeah.
Syringes should be labeled or filled at spot.
Yes. Yeah. So 3 cases we
Please
published at
continue.
the time. And as far as I mean, there might be more cases happening, but at least we have not made aware of it. So that doesn't mean it have not happened again, but at least awareness. Some changes, simple changes. Chlorhexidine solution taken off. Just use scrubs like that, rubbing things, and then separate trolleys for these, so that you know that that is all glue, thrombin, and one trolley, and this one. I think this is my last case, and I've got a few good spots. Quickly, I'll run through them afterwards. So this is a chest X-ray reported as normal, and subsequently, patient 6 months down the line came for a CT, and this was lung cancer there. And then when you look back at that chest X-ray, and when you put the previous image next to it, it strikes. I've shown the CT already, so I'm not going to ask questions now. Just also in the interest of time, I don't want to hold you all. So that's hilum is very dense and bulky. In isolation, sometimes one can call it normal. I can see why somebody is. It's easy to call it normal, but always compare with previous imaging, and that's when our eyes pick up that asymmetry between that one and that one. See that now it becomes quite obvious now when you put that next to it. Always compare a chest X-ray or any imaging with previous imaging. Then this becomes, it is very subtle, relatively dense. Many times we would call this normal and verify. If you call every little bit ILR, there will be loads of CT scans. We are very, very tight on resources. So this one, with the benefit of hindsight and comparison of previous imaging, it looks bulky, more dense. Okay. That's the case. I've told about the learning points already. I'll just go to good spots quickly. I'll run through. I don't know what the time is. Already 9. Is it okay, Dr. Khan, if I finish off in 5 minutes?
No, please continue. Don't worry.
Sorry, last time I was just okay. Admission with atypical chest pain. This is a good spots, few good spots, and this said flow limiting coronary artery disease was the question. So I'll just quickly go through. So the coronaries, I mean, they've correctly reported everything. I think is one of our trainee picked up this scan finding. I'll just go through. If anybody picks up anything, please put this. It's a good spot, very good spot. Okay, anybody see anything? Just put a comment. No, it's not ideal, not the right windows, not things. Just
Air. Somebody says air.
air. Okay, that was not for the good spot. Good spot was for this blush of contrast from LV, LA to RA. That's ASD, small ASD. See that?
Can you point it out, please?
Yeah, I'll just get the laser point. You see this? This blush of contrast. This is left atrium, right atrium. You should not have contrast blushing like that. Yeah, that's a small ASD. Happy? There. And that was subsequently confirmed as well. So intact septum there, no contrast. And then when you come up, there's a little contrast blush. So this was picked up, so that was nominated for good spot for the person. Pre-COVID, we used to give a box of chocolate. Now, with all happening online, these meetings, so that disappeared. We actually used to give chocolates for the person. John used to give beer in Leeds, a bottle of beer, ale. So this is another case. One of my colleague, Shailendra, who picked up. We name and shame in this part of the meeting. We tell the people who did this, so it's an appreciation. So nobody mind telling their names. One of the radiologists who moved from India and started working with us recently. He was reporting this CTPA. Anybody spot anything? They are PE. That's easy. This is the kind of cases where you once you see PE, effusion, report, move on. You got the finding, answer. Anybody spot anything else? Just quickly. It's very difficult. Anybody spot anything? Okay, he picked up something, filling defect in the left atrium, and he called it left atrial thrombus. It's very subtle, not correctly windowed here. Unfortunately, it's not correct for me to ask you this question. Patient subsequently, despite anticoagulation, he went on to embolize that. You can see in this case, he has got clots now in the right subclavian artery. So it has moved to subclavian artery. So it was left atrial thrombus. Now there's a clot in the same patient, subsequent scan. So this was picked up and this was nominated as good spot. Moving to the next scan, one of my good friend, he gave me this case. CT was done for kind of chest pain or something, or CT was done. But the registrar who reported this, I don't have the trainee name. Unfortunately, I should get the name from him. But picked up something very interesting, and it was correct. Anybody spotted this case? So the trainee picked up that. I'll just show you quickly. So I think the question was dissection. There was no dissection, so that question was answered. But the trainee said, if you follow the right coronary artery, so in here, just scroll the images, just watch that. It disappears, 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 and then fills again a little bit. Okay? Look at the other vessels. They're filling very well, reasonably well. Although it's not a dedicated gated cardiac CT, the trainee picked that and said there is occlusion, suspicion for an occlusion of an RCA, and patient who went on to have catheter angiogram, which confirmed the diagnosis, and probably they stented or whatever they did. So this was identified in the middle of the night by a trainee. So this was nominated for good spot. Another case, similar thing. This was done again for another reason, but the trainee, very astute eyes, very eagle eyes. Again, it's a trainee picked up this decreased enhancement when compared to the rest of the myocardium. I think that's a very, very good pickup in my view. I mean, it's a chest scan done for something else. You're not even looking at the heart. Heart is a very big blind spot for me, for many. And picked up this decreased enhancement and said there is some ongoing ischemia, and the patient went on to have catheterization, and that confirmed exactly in that location there was an occlusion. So that was treated. So that's, I hope you all appreciate it. See, look at the myocardium. This decreased enhancement when compared to that was a great spot, and we even published in our real newsletter, I think, this case. So good spot summary. Don't forget heart and aorta. Correct technique sometimes helps, and power of good spots appreciation. Few more good spots. I talked about power of good spots and appreciation in the first talk, so I'm just not going to tell anything. Just this one. Anybody spot anything in this chest X-ray? Dr. Khan, please tell me from the chat box.
Left hilar mass. Somebody
Is okay. That's also okay. Left hilar is okay.
dislocation.
No.
Left shoulder dislocation.
No, that was fine. Yeah.
Right cardiophrenic angle.
We occasionally see that sometimes we do get CTs for these things. It's okay. Yeah, it's okay. See, 130 people are watching this one, or 200 people, or 300. I don't know how many.
Right nodular lesion, left bronchus lesion, somebody has said.
No, that was fine. It's just pulmonary artery, I think. Just pulmonary artery.
Shoulder.
Okay, I'll show you.
Shoulder deformity, winging scapula.
No, that's all fine. I'll show the pathology. So it's hard. And the reporter picked up this nodular opacity in the right peribronchial region. And you should not see this. Right paratrachea comes along here. Just this little bulge. Can you all see that now? A little bulge. This was picked up and correctly commented this is an opacity here. And patient went on to have a CT. And CT confirmed a right lower lobe T1B lung cancer. By the way, this belongs to my wife. I always put my wife's good spot. It was nominated not by me. She was working in another hospital there. It was nominated. If you have a spouse as a radiologist, make sure you appreciate in your presentations. That's a learning point. So, Okay, everybody happy with that question? That case, yeah. So yeah, this was from another hospital. Yeah. Next question. Uh, very difficult. I'll just give away. This was a radiographer who came to me saying, Ram, I'm a bit worried about this patient. This X-ray was done for NG tube checking. That's the interest is why I want to say is once I say NG tube, sometimes that will lead to tunnel vision. Okay, NG tube is fine. She came and said, Ram, I'm not happy with this area here. And she showed me, windowed and showed me. She said there's some branching gas. Yes, I said I agree with her. We did a CT. It was ischemic bowel with uh, portal venous gas. It's very subtle, very subtle. This is not the best system to show this image. And she was very spot on. She came to me, said, I'm not worried. We got a CT abdominal. We looked at the abdominal pain, vomiting, NG tube inserted, NG tube check. We said to the call the clinician said this looks like ischemic bowel. They got a lactate, they got a CT, and patient went on to theater. So that was a really good spot. So we nominate everybody, whoever has picked up. So summary of learning points for this talk is, satisfaction of search is one of the commonest reason why we miss pathology. Like my relative case I showed in the first talk, you see something, you're looking, and then you stop looking at other things. Overcalling can cause. I'm not sure many overcalling cases. I have other presentation of overcalling. Fuse spine, think of unstable injuries and alert clinicians. It's very important because if we miss or something, it can cause catastrophic consequences. Lines and tubes, they save lives, but in wrong place can take lives. Prior imaging, clinical history can be useful, but can create a tunnel vision. Just don't completely go in one way only on the history. Just have a broader vision. Edge and scout, edge of the images, scouts. And then we talk about that strategic case, IRC system, WHO checklist, closed system, separate trolleys. And I thank you again, and thank you for all the organizers, and particularly to Dr. Khan